going to bring us into infancy. And I want to tell you there's a fair amount of overlap, mainly because we're still talking about that first year of life and all the things we need to assess. So we think about with infancy, we're going to start doing what we call child health supervision. This is where you do your assessment, you provide good and distal guidance. You're helping the parent know how to help that baby thrive, okay? And so promoting, you know, in a way that is positive developmental outcomes, health promotion. There's that good old Bright Futures. Isn't that a great Bible? Have all of y'all used Bright Futures, though? It's really a great tool. One of my favorite areas in Bright Futures is especially the social emotional section, because it has a lot of tips in there about helping parents understand why their baby cries and certain things and what they need and so forth. It's a really good section. Definition of an infant, and the newborn period is considered the first 1 to 2 months. A lot of you don't get into like splitting straws on this, but some people grew up on a newborn is the first 28 days. Some people say newborn is the first 30 days, first month. For the purpose of the exam, they like to look at it the first 1 to 2 months because of organisms that are more prevalent to cause infection. And I will tell you, on the exam, oftentimes they like to ask questions about babies that have been exposed to infectious agents and some of the sequelae and some of the problems that associate with it. So we're going to talk about that later on at the end of this chapter. The infant is the first year of life, first 12 months. We also know that there's certain things you're going to focus in on, such as gross motor cephalocaudal, that's the growth and patterns. Fine motor is proximal distal, cognitive sensory motor, and psychosocial is developing trust. There's your Bright Futures. Now, when we think about well-child checks, did anybody grow up on the old term EPSDT? Yeah. That was the way they used to call these well-child checks EPSDT checks, which is early periodic screening, diagnostic testing, you know, assessment. And that got so cumbersome. So now they just call them WCCs, okay? Well-child checks. And if you think about it here, it's from 2 weeks to a year. What you're going to do is at 2 weeks, then you follow with 2, 4, 6, 9, and 12 months. Did you notice up there the only one that they're not getting a vaccine is 9 months? What would be a good opportunity to do at that point? That's when the baby doesn't necessarily get stuck with a vaccine. It's a good time to check their H&H to see, because they've been started on maybe some solids. So it's a good time to start that. If they're discharged more than prior to 48 hours, first visit should be in 3 to 5 days. You know, these mothers are not born with an instruction manual. They need lots of support and lots of guidance to help them with their new baby. Do you remember, let me just make sure everybody understands this next little section. At the end of growth and development, that section was health promotion, and I went through subjective and physical and all that. We're now, I'm not going to go over all the aspects again, but anything you need to remember, well, what is subjective data? You can go back to that first chapter and review it. But it's common sense. You think about it. Subjective data is going to be how is the baby nursing or feeding, and, you know, sleeping, and, you know, things like this. So you know all that's going to be brought forward. So let's spend a few moments on physical, some of which we are going to see as an overlap to the perinatal. You're going to do, and I'm going to just kind of move fairly quickly, but length, weight, head circumference. We do head circumference up to 2 years. Serial measurements, dental development. I don't need to go over dental development again, but you're bringing that information forward. Vital signs, head size, shape, and fontanelles, which we reviewed. Head control by 4 months. And no head lag by 6 months. Let me just give you another little sidebar. Did you notice in the news lately they've been looking at autism? And they've been seeing kids with autism had in their history head lag. Did you know that? Just a little. It's interesting how we start, and then they're going to start studying that more. But it's just interesting how you pull that together. Assess neck masses and syndromes and skin variations. I'm not going to go over all that again, but you bring it forward. We think about the mouth, the throat. Are they getting too much or too little fluoride, sleeping with the bottle? Baby bottle caries. And I know you've seen pictures of horrific baby bottle caries and or your own patients. You're looking for tooth eruption. Maybe it's unusual sequence. Fissures at the lip corners called chelosis. Remember that term right here? That's when they're getting deficiency in terms of vitamins. Any type of an asymmetrical tonsillar enlarged tonsil area should be evaluated. You remember how you assess tonsils? Tonsils are looked at 1+, 2+, 3+, 4+. They should all be equal. One that's asymmetrical enlarged, you would be a red flag to look further for any type of a retropharyngeal abscess and so forth. The voice. Babies are cooing and making vocalizations, so you're looking at those sounds. And we're going to get into heart sounds, which I will do that in cardiac. Chest, they're diaphragmatic breathers. You're looking at the chest structure, and you're looking at gynecomastia, galactorrhea. It can be even up to 3 months because of maternal hormones. The abdomen, we've kind of talked about it. You know, on a newborn, you can feel oftentimes the liver edge palpated, but in adults, we don't. The GU, we already mentioned that, large scrotum testes phimosis. Here's a good picture for you of thinking about GU, abnormalities, hypospadias, which we viewed earlier. But musculoskeletal, think about this right here, Galeazzi sign, where one is, but what if you had bilateral hip dysplasia? They may be equal. And we know we don't take one finding without looking at all the other findings. So Barlow's and Ortolani's Ollie sign, Galeazzi sign, and skin fold thickness are all going to be key. And again, we'll talk about that with musculoskeletal. Looking at first lateral curvature, lymph nodes. Did you realize that the tip of your pinky is about 1 centimeter? So when you use your assessing for nodes, think about that's 1 centimeter if you had to describe the size. 2 centimeters cervical may be a normal variant. Shoddy nodes really reflect a past infection. And anything that's supraclavicular up above the clavicles probably need to be further investigated. So we're going to come into developmental monitoring. And you all remember we talked about Denver earlier. But when you pick up a child has an abnormality on Denver, say they can't do something averagely, and you want to get a little bit more of a better picture, we got to do another test. So often they'll do one of these other tests. Now, the one that's real common you'll see is Bailey's Scales of Infant Development. That's one that, because remember we said at least 2 for any type of an abnormality, so a battery. And a lot of times we, in private practice and in your clinics, don't do the assessments right there ourselves. We will send them to a psychometrician or a psychologist. Assessment, motor skills, survival, reflexes. Babies, the job of a newborn is to do what? Breathe, feed, and temperature control. And those are where their main survival reflexes are. And I think this is an important topic here, is to look at cognitive development. And I can tell you this because this is something that I experienced on one of my exams. A question that came before me was, and I don't remember exactly how it was set up, but the essence was, do babies have pearl law? No, newborns do not. The accommodation comes with times. They'll have pupils equally round reactive to light, but the A accommodation comes with development of the musculature. We also know visual acuity, hearing. We talked about babies like high-pitched tones. We also think about sensory motor development. They adapt to their environment. They're very sensory motor learners. Some babies have different temperaments. They're easy, maybe slow to warm up, difficult cyclical. There's also a component of fear. Now, fear is tied into what? Developing trust. So when you have a stranger anxiety at 6 months and separation anxiety 8 months, that's part of, you remember when if you have a 6-month-old and you go over to take the baby from the mother to start examining the baby, that baby's going to go crazy. Okay? So you want to let them be with the mother and so forth, and let them size you up in the room while you're assessing, getting information. I will tell you, the fear component, stranger and separation, do occur again another round in toddlerhood between 16 and 18 months. So you may see it, and it's part of just kind of zoning in, making sure that baby has what? Gotten that trust down pat. Does that make sense to you? Now, attachment's important. If the infant doesn't develop trust, then they're going to have attachment issues. We want them to be trustful and be secure, but they may become insecure and be avoidant, anxious, and disorganized. So some of the intistatory guidance that we want to think about, breast and bottle feeding, and that's something I need to share with you. Not a lot of questions, if any, on any types of formulas, because AAP and World Health Organization does what? They advocate for breastfeeding, so they kind of follow that standard. We already did the supplements, iron, vitamin D, and fluoride. One that I didn't talk about but was in your notes earlier was vitamin B12. Usually B12 is not a problem unless the mother is malnourished or she's a vegetarian, a vegan. Okay, then you may see that they're not getting enough of the iron support and so forth. And we did nutritional requirements, but let's talk about when to introduce foods. When do you introduce foods? Pretty much maternal iron stores start to deplete around 6 months, and we said at least breastfeed for 6 months. So we start thinking about introducing foods such as cereals with iron. Then you go into like vegetables, because babies like fruits. They have an affinity for fruit, sweet, and then meats and so forth. What are some of your common allergens? Think about eggs. What part of the egg? The white. The white is the most allergenic part of the egg. Absolutely. Honey should be avoided. Nut products, nuts. I know you've been in the grocery store and you've seen these mamas walking through the store giving the little infant that can barely hold the head up a chip. Have you seen them eat, different things? And so, you want to think about some of those citrus fruits, strawberries, things like that can be very much. Weaning, they don't really ask a lot of questions on weaning, but let's talk about for a minute for weaning. If we're really advocating for breastfeeding, usually the last breastfeeding period that is usually given up is usually the nighttime breastfeeding. But nighttime breastfeeding for an older infant that's getting ready to transition is usually not for nutrition. It's for that mother-baby closeness and so forth, and support and security. So you want to think about that. And then for weaning, if they were on some type of formula, you think about it. Formulas can be very iron poor unless they're iron fortified, but even at that, they don't have enough iron often because you've got to supplement with solids. If you have a newborn that's getting too filled with whole milk and or formulas that are, not got the right amount for their growing where they are, you need to think about anywhere around 8 to 9 months, 32 ounces of whole milk, because babies are taking whole milk, which is very iron poor. These are the kids that are going to get anemic. So you want to have them start to get rid of getting full off of the formula and the milk so they can take in more solids. It's kind of a scales of balance. Dental health. Did you see up there dental visits by a year? You know why? They did some studies on this. It was found that 70% of all caries were found in children around the age of 2 years of age. That's huge. So in those little primary teeth, but that's part of the habit of the family. So how do babies get this? Well, a couple things. We do encourage them, if you talk to the dental community, they would say at the first sign of the first tooth, brush the teeth. In the interim, rubbing the gums, wiping the gums down after they've taken in formula, breast milk, and so forth is important. Do y'all know when you're supposed to start flossing? The first time 2 teeth touch. Isn't that interesting? So dental health is very important. So they suggest, because of the potential for caries, that you need to get them into a routine seeing a dentist by 1. It used to be 3 years of age, and that changed in 2006. So just to but the problem is what? We don't have enough pediatric dentists, let alone enough dentists that will take Medicaid, right? So a lot of this is left up to you all as primary care providers to do a lot of dental health in your practice. Sleep. They sleep a lot. Avoid cohabitating with sleep. As a matter of fact, cohabitating is very cultural. There are some cultures that sleep with their babies, and you have to work with that. Now, there are some states, I think it's New York, maybe New Jersey, they were having a huge campaign about avoiding sleeping with your baby, because remember that mother that was in the news not too long ago where she lost her second child because she rolled over on him and the baby was suffocated? So there's a lot of teaching that goes on there. Also, we know that babies have an innate way of self-soothing themselves. So they can then, when you think about it, when you put the baby down and get into a routine, you really shouldn't go back up and pick them up, because then they get used to that. Remember, they can problem solve, sensory motor. So if they go and they cry, you come in, you pick them up. I learned from that. I'm going to keep doing that. So you want to kind of get them, if you can get a parent to be taught to get into a good sleep habits, it's golden. Developmental warning signs. This is part of the knowing of the growth and development. Any visual delay, not raising their head when lying on their stomach by 3 months, not picking up a toy by 6 months because they have what? Eye-hand coordination, they've been transferring objects. No reaction to noise, voice, don't laugh or seek interpersonal contact, or don't sit up. These are all definitely red flags. And so we're going to think about a couple of health issues that we want to talk about. Fever in a very young infant. Well, do you all realize that rectal temp is the most accurate temp, okay? And we can see that temperature can be quite variable in the younger the infant is, more variable you may have, because they have difficulty thermoregulating. Very young infants. We also know that fever in an early infancy, especially in the first 2 months of life, you want to think about a couple of things. Is it maybe bacterial or viral? Well, pretty much when we think about 40% of fevers have been known to be more viral. When you get into bacterial infections, and in that first month or two, good old group B streptococcus and gram-negative enteric organisms like E. coli are common and can cause them to have, so those bacterial agents can cause, and usually when you have a bacteria, if they are able to regulate, their temperature will be higher. And the second month, above the second month, good old strep pneumoniae and H. influenza. As a matter of fact, ear infections, 30% of ear infections are caused by strep pneumoniae, and about 20% are caused by H. influenza. So how do you know an infant the degree of their illness? You have to look at behavior. If I have to impress upon you, children who are pre-verbal, who can't tell you where they hurt, you have to not, especially if they can't get a good accurate temperature because they can't thermoregulate, you got to look at behavior. So you want to think about mild illness. Are they still alert, active, smiling, feeding? Are they moderately ill, such as fussy, irritable, but they continue to feed? As a matter of fact, babies that are moderately ill may feed pretty voraciously because that's comforting to them. And then if you get a severely ill baby, any baby that's listless, red flag, I think you probably know that, cannot console, feed poorly, not at all, and need to be admitted to the hospital. You always want to consider with fevers, especially with behavior changes, a UTI. Just like the elderly get what? A change in their behavior, right? UFNPs. So do the very young. So always consider UTIs. And again, a lot of it's E. coli, which is something that we see. Now, management, well, let's talk about this. We got all kinds of things that ways to practice. Some of you say that you're getting ready to graduate. Some of you have graduated. Some of you have been in practice. One other little sidebar, if I could give you. Please, for the exam, if you're sitting for the exam, do not take to the exam what you did in your practice, because not always what you do in your practice or what your preceptor told you is the correct thing for the exam. So what I wanted to tell you is, remember how we parents used to do what? Alternate ibuprofen and acetaminophen? The World Health Organization and the American Academy of Pediatrics recommends only acetaminophen. Okay, that's their current recommendation. First line therapy, 10 to 15 milligram per kilogram every 4 to 6 hours. If you give ibuprofen, it's usually around 6 months or older, but it should be one or the other, not alternating, because parents get confused. They overdose. They forget, did I give it this, did I give it that, and so forth. Now, you're not going to get with Tylenol, you're not going to get into toxic levels following this. You know where toxic is? Toxic is considered 140 milligrams per kilogram. That's huge. We're talking 10 to 15, okay? Don't alternate. And this is another reason why they pulled all these products off the market in terms of cold preparations. Remember how parents were buying, they didn't know, they got a little extra. They got 3 different products that had Tylenol in it, okay? And then the child got too much Tylenol. So we want to, be cautious of that. So That is the topic that I want you to think of. They always ask pink pig usually questions about babies with fever. Now, in a little bit, we're going to do meningitis and so forth, and so, that's going to be tying into behavior.